Hi class, I'm Dr. Fife. I want to welcome you all. I'm going to go over some structure and function in the musculoskeletal system. The bones, these give form to the body, support tissues, and provide protection and permit movement. There's ground substance, minerals, especially calcium, that make the bones rigid. Bone contains three types of cells. We have osteoblasts, osteocytes, and osteoclasts. Osteoblasts are the bone-forming cells, and these produce osteocalcin and other substances. These initiate new bone formation by synthesis of osteoid when stimulated by vitamin D. Osteocytes help maintain bone by signaling osteoblasts and osteoclasts to form and resorb bone. Transferred osteoblasts become trapped or surrounded in osteoid. Osteoclasts, these are the major bone resorbing cells, and these are responsible for remodeling. Types of bone tissue, we have bony or osseous tissue that is compact or cortical bone, and spongy or calcaneous bone. Compact bone is about 85% of the skeleton, and spongy bone is about 15%. Both contain the same structural elements and are present in most all bones. The major difference is the organization of the elements. With compact bone, this is more highly organized, solid, and strong. And there's the Haversian system, the central canal, concentric layers of bone matrix, tiny spaces between the lamella, which are the lacuna, bone cells of osteocytes, small channels or canals called caniculi. Spongy bone is less complex and lacks the Haversian system. All bones are covered with a double layer connective tissue called periosteum. Characteristics of bones, the human skeleton has about 206 bones. The axial skeleton is about 80 bones that make up the skull, vertebral column, and the thorax. The appendicular skeleton is 126 bones and makes up the upper and lower extremities, the shoulder girdle, and the pelvic girdle. The skeleton contributes to about 14% of the weight of the adult body. Now, characteristics of bones, the long bones are longer than wider, and they consist of a diaphysis, or a narrow tubular midportion. It merges into a broad neck, metaphysis, and broad ends, epiphysis. In children, the epiphysis is separated from the metaphysis by a growth plate known as the epithelial plate. And flat bones, ribs, and scapula, there are two plates of compact bone roughly parallel to each other. Bone repair, the remodeling process, there's microscopic injuries, fractures, or surgical wounds that can occur that need to be repaired. There's hematoma formation, procallus formation, callus formation, which involves osteoblasts, and callus replacement, which is osteoblasts, and then remodeling occurs. Now moving on to muscles, there's more than 350 named muscles, and almost all of these are paired. Fusiform muscles are elongated muscles shaped like straps and can run from one joint to another. Pennate muscles are broad, flat, slightly fan-shaped, with fibers running obliquely to the muscle's long axis. An example of that is the deltoid. There's fascia, that's three-part connective tissue framework. And we have voluntary, striated, and extrafusal types of muscles. Voluntary muscle is controlled by the central nervous system. Striated describes the striated or striped pattern of skeletal muscle. And extrafusal distinguishes skeletal muscle fibers from other contractile fibers located within the sensory organ of the muscle. Okay, now let's go over some alterations in musculoskeletal function. We have fractures. This is a break in the continuity of bone. This can be classified as complete, where the bone is broken all the way through, or incomplete, where bone is damaged but still in one piece. Now, it could be open, which was formerly called a compound fracture, and this occurs when the skin is broken. It can be closed, which was commonly referred to as, formerly referred to as simple. This is if the skin is not broken. Clinical manifestations of fractures. This can vary according to the type and the site of fracture and any associated soft tissue injury that may occur as well. There can be impaired function, deformity, swelling, muscle spasms, tenderness, pain, and impaired sensation. Management is to realign the bone fragments, which is called reduction, and hold into place, which is immobilization. Here's just a picture describing the different types of fractures. Support structure trauma. We have tendons that are fibrous connective tissue that attach muscle to bone. And then ligaments are a band of fibrous connective tissue that connects bone to joints. A strain is a tear in a tendon, and a sprain is a tear in a ligament. Avulsion is complete separation of tendon or ligament from its bony attachment site. Clinical manifestations, they may have pain, soft tissue swelling, changes in contour, dislocation, or subluxation of bones. A subluxation occurs when the contact between the two joint surfaces is only partially lost. Tests for musculoskeletal function, some different diagnostics. We can be looking at gait analysis, check serum calcium and phosphorus levels, and do other imaging, such as X-rays, which is usually the standard initial imaging tool for a bone evaluation. CT scan can look more at soft tissue, bone marrow, and crystals. MRI, metastatic bone lesions. We can look for infections, marrow edema, bony erosions, osteonecrosis, fractures, and other pathological conditions or changes. PET scan can give a detailed image of the bone. Nuclear medicine studies look at the metabolic activity in bone and soft tissue. The DXA, or dual photon absorptiometry, this looks at the density of bones and fracture risk. Serum bone-specific alkaline phosphatase, or BAP, this is a marker of bone formation. We can look at the test of joint function with arthrography, which is an injection of dye. Fibrocartilage, meniscus, knee, and rotator cuff of the shoulder, that test can be useful for those areas. MRI, again, looking at soft tissue, and an analysis of joint fluid to look for if there's sepsis or inflammatory or non-inflammatory joint changes. Test of muscular function, we could do an electromyogram or EMG, which is a summation of action potentials of muscle fibers in each motor unit. Okay, let's move on to some musculoskeletal alterations. Let's look at some metabolic bone disease. We have osteoporosis. This is also referred to as porous bone. The bone tissue is normally mineralized, but the density of the bone is decreased and the structural integrity of the trabecular bone is impaired. Now we hit peak bone mass around 30 years of age, and it decreases from there. Postmenopausal or primary, this is the most common type of osteoporosis. It occurs primarily in middle-aged or older women due to estrogen deficiency. This also contributes to osteoporosis in men. There's increased bone resorption relative to the rate of bone formation. Secondary osteoporosis is caused by another condition. This can be from hormonal imbalances, medications, or substances such as tobacco or ethanol alcohol. Normal bone mass is greater than 833 milligrams per centimeter squared. The patient is considered to have osteopenia when there's decreased bone mass between 833 and 648. Osteoporosis is when the bone mass is less than 648 milligrams per centimeter squared. A DEXA scan can be done, and the T-score of less than 2.5 and below is indicative of osteoporosis. Sex hormones of estrogen and testosterone are significant in premenopausal bone maintenance. Poor nutrition, insufficient intake or malabsorption of dietary minerals, especially calcium, contributes to osteoporosis. And a patient may even have regional osteoporosis, which is confined to a region or segment in the appendicular skeleton. And the picture here is just showing the differences between the bones. More on osteoporosis. This occurs when remodeling cycle is disrupted. The process of bone resorption and bone formation leads to an imbalance in the coupling process. We have osteoclast differentiation pathway directed by proliferation, differentiation, fusion, and activation. Process are controlled by hormones, cytokines, and paracrine stromal cell microenvironment interactions. The Renkel system is involved, which is the receptor activator of nuclear factor Kb ligand. And clinical manifestations are going to depend on the bone that's informed. Patient may have bone deformity, pain with a fragility fracture. Fractures can occur, and the patient may have kyphosis of the spine. And moving on to more metabolic diseases, we have osteomalacia. This is a metabolic disease. There's inadequate and delayed mineralization of osteoid in mature, compact, and spongy bone. Remodeling is normal, but mineral calcification does not occur. Now, this is similar to rickets, but this occurs in growing bones of children. Osteomalacia and rickets are rare in the US, primarily because of dietary intake of vitamin D. A vitamin D deficiency can lead to either osteomalacia or rickets in children. Clinical manifestations, varying degrees of diffuse skeletal pain and tenderness. There can be bone pain, typically between the joints rather than within them. Patient may have pain in the hips, muscular weakness, a waddling gait, or bowed knees. And here it's showing the differences between rickets and normal bones. Infectious bone disease, osteomyelitis. Bone infection can be caused by bacteria, fungi, mycobacteria, parasites, or viruses. Osteomyelitis can be exogenous, which the infection enters through a fracture, wound, or a procedure. Or it can be endogenous, where pathogens are carried in the blood from a different site of infection. Hematogenous is an infection that spreads from the bone to the soft tissue. Usual culprits for this are Staph aureus, MRSA, Group B strep, or H. influenza, or Salmonella. And this can occur with cutaneous, sinus, ear, or dental infections. Clinical manifestations are going to vary with age and the site of involvement, the initiating event, and the infecting microorganism or organism. Now, sequestra, this is pieces of dead bone that are devascularized and devitalized bone, and involucrum, which is new periosteal bone. So when there's the presence of sequestra and involucrum, this indicates the disease is highly aggressive or established. All right, let's look at some disorders of the joints. We're going to go over osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, and gout. Osteoarthritis, this is an age-related disorder of the synovial joints. Local areas of loss or damage to articular cartilage, new bone formation of joint margins, osteophytosis, and subchondral bone changes, varying degrees of mild synovitis and thickening of the joint capsule. Inflammation is an important feature of osteoarthritis. Now, the exact cause of this is unknown, but the pathology centers around load-bearing areas. We have osteophytes or bone spurs that can develop, and this is caused by conditions that damage the cartilage. Clinical manifestations include pain and joint stiffness. Rheumatoid arthritis, this is a chronic systemic inflammatory autoimmune disease. There's joint swelling and tenderness, and also destruction of the synovial joints. The first joint tissue affected is the synovial membrane, which lines the joint cavity. Immunoregulatory cytokines contribute to joint damage. And inflammation may spread to articular cartilage, fibrous joint capsule, and surrounding ligaments and tendons. Ligaments and tendons. Joints most commonly affected are the fingers, feet, wrists, elbows, ankles, and knees. Patients can also have fever, malaise, rash, lymph node or spleen enlargement. And they may have Raynaud phenomenon, in which there is a transient lack of circulation to the fingertips and toes. Ankylosing spondylitis, this is an inflammatory arthropathy, chronic inflammatory joint disease that is characterized by stiffening and fusion, or ankylosis, of the spine and sacroiliac joints. There is a high association with the HLA-B27, and clinical manifestations include low back pain and stiffness. This low back pain often begins in the early 20s. And spinal changes that occur include lumbar lordosis diminishes and kyphosis increases. Okay, moving on to gout. This is an inflammatory response to uric acid production and excretion, resulting in high levels of uric acid, also known as hyperuricemia. Other factors, age, there's a genetic predisposition, there's an X-linked alteration of enzyme HGPRT. Excessive alcohol consumption can lead to gout, obesity, and different medications, especially thiazides. Lead toxicity can also cause gout as well. There's prolonged accumulation of crystal leads to gouty arthritis. Crystal deposition, there's tophi, which are small white nodules. And the clinical manifestations, hyperuricemia, monoarticular arthritis, deposits of tophi, renal disease, and renal stones. Often this occurs in the great toe, showing here in the joint, but it can occur in other joints as well. Now, disorders of the skeletal system, skeletal muscle, we have fibromyalgia. This is chronic, widespread joint and muscle pain. Patient may also have fatigue and tender points. There's increased sensitivity to touch, an absence of systemic and localized inflammation, fatigue, non-restorative sleep, anxiety, and depression. This is most common in women, and the peak age is 30 to 50 years. Precipitating factors can bring this on, such as the flu or a viral illness, chronic fatigue syndrome, HIV, Lyme disease, physical trauma, emotional trauma, and medications. This is considered a chronic pain syndrome. And clinical manifestations are diffuse chronic pain in the 9 pairs of tender points. Now, chronic fatigue syndrome, also called myalgic encephalomyelitis. There's profound fatigue, neurologic energy production, and immune impairments. The symptoms are the result of CNS dysregulation, CV and immune abnormalities, dysfunction of cellular energy, metabolism, and ion transport. Lower blood perfusion to the brainstem. And the clinical manifestations are unrestful sleep, muscle pain, non-inflammatory joint pain, headaches, flu-like symptoms, memory or concentration problems. All right, moving on to the alterations of musculoskeletal function in children. We can look at some congenital defects. We have syndactyly, which is the most common congenital defect of the upper extremity. There can be webbing of the fingers. Simple webbing involves soft tissue, which can be treated with surgical release. Or it can be more complex where there's fusion of bones, nails, and soft tissue. This may be associated with absence or anomaly of bone or neurovascular units. And there can be vestigial tags, which is an extra digit. Developmental dysplasia of the hip. This is an abnormality in the development of the proximal femur, acetabulum, or both. Most often present at birth, but this can occur later in infancy. Excuse me, I'm supposed to say later. Risk factors, there's family history, female gender, metatarsus adductus, oligohydramnios, first pregnancy, and a breech presentation with a pregnancy can cause this. A subluxated hip, the hip maintains contact with the acetabulum, but it's not well seated in the joint. And there's acetabular dysplasia. And this is just showing the picture here where that's not seated in the joint. Abnormal density or modeling of the skin, osteogenesis imperfecta. This is brittle bone disease. There's a genetic mutation in the gene that codes for the type 1 collagen, which is the main component of bone and blood vessels. The severe form is evident at birth because fractures and deformities occurred in utero. There's a less severe form, may not be evident until the child begins to walk. Pathophysiology, there's a synthesis of collagen, and clinical manifestations include osteoporosis, increased rate of fractures, bony deformation, triangular facies, vascular weakness, possible blue sclera, and poor dentition. Now, rickets, this is a disorder in which growing bone fails to become mineralized or ossified, resulting in soft bones and skeletal deformity. There's insufficient vitamin D, insensitivity to vitamin D, wasting of vitamin D by the kidneys, or the inability to absorb vitamin D and calcium in the gut that contributes to rickets. Patient may be listless, irritable, have hypotonia, or muscle weakness. Now, scoliosis, this is a rotational curvature of the spine, most obvious in the anterior-posterior plane. Non-structural posture, leg length discrepancy, and may have pain. Structural, there's vertebral rotation. There's abnormality of the CNS involving the balance mechanism, and there is a genetic component to scoliosis. Osteomyelitis can occur in children. This is an infection in the bone. Bacteria enter the bone through the bloodstream and lodge in the medullary cavity. When there's sequestra, these are sections of dead bone and pieces of dead bone. Involucrum is the appearance of periosteal new bone, and this occurs in children often in the long bones. Juvenile idiopathic arthritis, this is inflammation of connective tissues, primarily affects the large joints. There's systemic manifestations that occur, and there's 3 distinct modes: arthritis in fewer than 5 joints, or polyarticular arthritis; arthritis in more than 5 joints, or polyarticular arthritis; and systemic or still disease. Treatment for this is supportive. And this just lists here different areas where it can be causing some clinical manifestations seen in the patient. Osgood-Schlatter disease, this is tendinitis of the anterior patellar tendon. The patella is embedded and associated osteochondrosis of the tubercle of the tibia. This is most common in pre-adolescents and adolescents who are in sports activities. The incidence is higher in boys than in girls. And the severity can vary from mild tendinitis to complete separation of the anterior extension of the tibial epiphyses. Clinical manifestations: pain and swelling in the region of the patellar tendon and tibial tubercle, and there can be tenderness to pressure. Okay, and lastly, we'll go over Duchenne muscular dystrophy. This is the most common of the muscular dystrophies, and it occurs only in boys. So there's an X-linked inheritance in half of the cases. There's deletion of segment of DNA or single gene defect, or there's dystrophin, which is a protein encoded by the gene. Dystrophin mediates anchorage of actin cytoskeleton to the basement membrane, and there's poorly anchored fibers tear. Free calcium enters muscle cells, causing cell death and fiber necrosis. Clinical manifestations: slow motor development with progressive weakness and muscle wasting, and the patient may have a waddling gait. Complications include a compromised pulmonary function and kyphoscoliosis. Diagnosis is confirmed with genetic testing. The CPK level is increased to more than 10 times normal and with diagnostics. Genetic counseling is indicated in patients with Duchenne muscular dystrophy. And this just shows the different statistics here in different areas that it can impact the body. Now that's all I'm covering on musculoskeletal. If you have any questions, please let me know. Please remember to review the entire chapters. You're responsible for knowing the content in the entire chapter, not just what was covered here. Again, please let me know if you have any questions. Thank you. Have a great day.